Please begin.
Good afternoon, everyone. On behalf of PIMSR Parul University, it gives me immense pleasure to invite our speaker, Dr. Anshu, for the seventh webinar organized by Quality Assurance Unit and Medical Education Unit of PIMSR Parul University, and the title being Lean Six Sigma, Evaluating Quality in Healthcare and Education. Before we start out the session, I would like to add few points, very important. Although if I want, I can go for hours and hours together to introduce Dr. Anshu, but with just a brief interview, I would just like to say, Dr. Anshu at present, she's working as Director, Professor of Pathology at Mahatma Gandhi Institute of Medical Science, Sevagram. She has been awarded a Commonwealth Academic Staff Fellowship at the Guy and St. Thomas Hospital in London. She has also been awarded as CMCL Famer Fellowship from Ludhiana 2007 and Famer Institute Fellowship from Philadelphia 2009. In 2012, Dr. Anshu was awarded as International Fellowship in Medical Education from Famer USA, which enabled her to complete her Master's in Health Profession Education from Massachusetts University with distinction. She was awarded as DBT Clinic Fellowship in Genetics Diagnosis in 2021 and served as Southeast Asian representative on the board of directors of TUFA, that's the Network Towards Unity for Health. She was president of Academy of Health Profession Education for the year 2022 and is a global faculty member for the International Famer Institute Philadelphia, USA, and East African Famer Regional Institute, Uganda. She serves as a quality assurance member for the International Famer Institute, Philadelphia, and SMU Famer Regional Institute, China. She has been a IQAC coordinator for the past 15 years, and she has helped me a lot for that. And presently, she's also MEU coordinator at Institute MGIMS Sevagram. She has edited a book along with Dr. Tejinder Singh sir, titled Principles of Assessment in Medical Education. She has over 60 peer-reviewed publications and 30 book chapters on pathology and medical educations to her credit. The list, I can speak, it's on and on. But without taking Dr. Anshu's time for the topic, I would like her to start. Welcome, ma'am.
Thank you, Pooja. Thank you for inviting me to speak. It has been a huge challenge for me to find material on this topic and to prepare it, but it has also been fun. So let me start by sharing my slides. Is it visible?
Perfect.
Right. Okay. So good afternoon, everybody. And I see a lot of friends here. So hello to everybody. Today, we're going to talk about how to use Lean Six Sigma in elevating quality in healthcare and education. So, but before I start, I would like to know how many of you recognize this gentleman. Do you know who it is? I can't see your chat, so Pooja will help me if somebody's writing something in the chat. Does anybody know who this is? He's one of my favorites.
No inputs. Even I
No
don't know.
inputs. Okay. So this is Dr. Atul Gawande. Now all of you know who he is. He is a surgeon. He is a general surgeon and an endocrine surgeon. And of course, he is the bestseller author of 4 important books. And today, let me start by narrating a story that Dr. Atul Gawande writes in his book, Better. About 20 years ago, in American hospitals, central line infections, that is, bloodstream infections caused by catheters inserted into veins, were killing thousands of patients every year. These infections were not rare accidents, they were happening all the time. And treating them cost hospitals millions, and yet they were often seen as an unavoidable part of medicine. Then something remarkable happened. A physician named Dr. Peter Pronovost tried a very simple intervention. He created a checklist for doctors and nurses to follow each time they inserted a central line. And these steps were not new. It said wash your hands, clean your skin with chlorhexidine, use a full sterile drape, avoid touching the tip of the catheter. So these are things which everybody already knew. It was nothing new in this. But the checklist standardized the process, ensured that nothing was missed. And along with it, he empowered nurses to stop the procedure if a step was missed. So the results, the ICUs in Michigan, there, all the infection rates plummeted by more than 60% within 3 months. Over the next 18 months, the project saved more than 1,500 lives and nearly $200 million in cost. This lesson is here that it wasn't that doctors suddenly became smarter. The lesson was that even highly skilled professionals need better systems. And when you reduce waste, variation, and defects in a process, the impact is enormous. Now imagine if something as simple as a checklist can save thousands of lives in ICUs, what could structured approaches like Lean and Six Sigma do across healthcare and even in our medical schools? That's what we are going to explore today. So, the objectives of my session will be that first, I will go into a little bit of the history and the core principles of Lean Six Sigma, which will help you appreciate the importance of process efficiency and quality improvement in healthcare delivery and health professions education. We will together identify opportunities where you can apply these Lean Six Sigma concepts in healthcare settings. And it won't be possible in 1 hour to explore all the tools and techniques, but some tools and techniques which you can use to change the mindset about in students and faculty and how we can apply these strategies in health professions training programs. Those are my session objectives. And since the first time when I told people I'm talking about this topic, most of them said, what is Lean Six Sigma? Nobody seemed to know it in medicine. So I will go a little into what exactly Lean Six Sigma is and how these principles emerged. So the story starts somewhere after World War II, where the US almost brought Japan down to its knees. And along with everything else, the Japanese mobile industry was functioning at a loss. Sales were low, the quality was poor, production was bad, and uh, the Japanese automobile industry was far, far behind the US automobile industry. And at that time, we had in the Toyota factory these two gentlemen, Taichi Ono and Shigeru Shino. Both of them were Japanese industrial engineers, and they came up with a plan. And uh, this plan was called the Toyota Production System, and in some places it is called the Toyota Way. So, Taichi Ono was a man who believed that wisdom is given equally to everybody. The point is whether one can exercise that wisdom. So he traveled to US. He actually went and explored the Ford factory to see what they were doing differently from Toyota. But what inspired him was not the factory. There were some principles he picked up from there, but the supermarkets in the US. So he found, or he came up with this theory that the best way to manage cost was to eliminate waste in every form. And in the supermarkets, he noticed that the moment a customer picked up an item from the aisle, it was instantly replaced. And there was no gap between somebody coming and taking something and uh, somebody else coming and replacing that stuff. So, whereas Toyota was struggling because whenever customers wanted spare parts, it took days and days for the spare parts to reach, and people were unhappy with Toyota at that time. So, he came up with this concept called Kanban. So, Kanban basically says that you keep your inventory in two separate um, piles or two separate containers. So, or two separate cupboards. So, the moment in the first pile you come to the last item, when you start opening that last item, send a request to reorder that from the second pile. So that way you don't have too much of a material which is going to waste, and you don't have too less, and the gap is also there. So that was the principle that Taichi Ono started. But these principles in Japanese were the Americans found very inspiring, and they labeled it the lean principles. Okay. But when you look at the lean principles, the Japanese, they talk about eliminating the 3 M's. And these 3 M's are Muda, Mura, and Muri. So what do these Japanese terms mean? Muda refers to activities in processes, in terms of machinery and people that do not add value to all these things. Mura refers to variation, so that there is unevenness in customer demand, in process times, or other variations. So the workload is not balanced. And Muri is overburden or inefficiency, which results from too much Muda or Mura. So all of these 3 M's, we have to eliminate these different kinds of wastes to streamline the process or the flow. And remember, this is all to do with manufacturing at the moment. Now, so far it was the Americans who were the lead, but suddenly the Americans became threatened because now the Japanese started using different principles and they were way, way ahead of the Americans. So somewhere in 1987, Motorola took the lead, and there were two gentlemen here, Bill Smith and the CEO of Motorola, who's Bob Galvin, and they came up with the Six Sigma quality program. So Six Sigma, the core idea was that you reduce the defects and the process variability by applying rigorous statistical methods. So here the principle was that you collect data, produce evidence, and then decide what to do. So because of Jack Welch of General Electric Motors, this became more and more popular. Now, if you're wondering why where this term Six Sigma comes from, it actually comes from statistics, where you're talking about the normal distribution or the bell curve. So 1 sigma represents one standard deviation away from the mean. So, and in terms of defects, they say that if a process represents 6 sigma, it is of extremely high quality, but the defect rate is said to be extremely low, only 3.4 times per million. So if you're taking something like quality as we accept it, it's 99% quality is good quality. But if it's 6 sigma quality, it's 99.999997, or that is the improvement in quality. Because when you talk in terms of maybe a patient, then even if 99% means there are going to be at least 1,000 people dying per week, and we can't afford it. So we are looking for the 6 sigma quality in those terms. Now, what is the difference between the lean approach and the 6 sigma approach? I want to do a comparison here. Remember, lean, the focus is on speed. The focus is on looking at the process flow and trying to reduce waste. Whereas in 6 sigma, the focus is on precision, on reducing defects, and collecting evidence. And this is data-driven problem solving. So this is an evidence-based approach. So lean, the weaknesses are that it lacks statistical rigor, but 6 sigma, it lacks the holistic view of the process, the flow, and the waste. Now, if you look at these two things in terms of practical application, 6 sigma works if your project is huge, if you're working for a big company, because no 6 sigma project is small. A 6 sigma project, when you're collecting data, producing evidence, convincing people, coming to precision, this takes at least a year to do any 6 sigma project. And this is expensive. It requires lots of people. This is not true with lean. Lean is something which you immediately look at something and you can change it. So the basic difference between lean and 6 sigma is that lean focuses on the process and waste reduction. It focuses on efficiency, whereas 6 sigma, it focuses on quality and variation control. It focuses on standardizing something, and it focuses on effectiveness. So people wanted something which is not very difficult to do, like Six Sigma, and still have a bit of statistical rigor in it. And so what they did was they merged these two processes or standards together. And this is Lean Six Sigma is the new term for it. And this is a continuum between these two principles. And this book, Leaning into Six Sigma by Barbara Wheat and friends. So this tells you about how the journey happened between Six Sigma and Lean Enterprise. So I'll just summarize what I just said in terms of how different or how complementary these two systems are. So in Lean, we're looking at eliminating waste and improving the flow. In Six Sigma, your focus is on reducing defects and minimizing variation. When you're merging Lean Six Sigma or LSS, we're using both these principles together. I've talked about the origins. In the 1960s, it is this Lean principle started at TPS or Toyota Production System. Six Sigma started later in the 1980s, late 1980s by Motorola. And LSS, the merged version, happened somewhere in around 1990 to 2000s. They use different tools, and I will talk about all these tools one by one. But in LSS, we are using a hybrid toolkit. So wherever, depending on our needs, we can use any of these tools. But there's a difference in the mindset. Lean focuses on developing a culture of continuous improvement, whereas whereas Six Sigma, like most Americans, is data-driven problem solving. So what we need actually is a balance between that culture of improvement and gathering data. So that is what LSS or Lean Six Sigma does. So to summarize this part, Lean Six Sigma is a process improvement approach. It uses collaborative team effort, and it seeks to improve performance by systematically removing operational waste. That's the first approach. And the second is by reducing process variation, or rather standardizing all the different processes. So this is what Lean Six Sigma is. I hope this is clear by now. So I'd like you to do a small activity. Take a sheet of paper and write down 3 things that need to be changed in your clinical unit, if you're a clinician, or in your workplace or department to improve its effectiveness or efficiency. You know your department or your clinical unit best. Write 3 things that need to be changed, which can make it more effective or more efficient. I understand that these are personal things. You might not want to share it, but go ahead. You can write it for your own sake. You don't have to share it. Okay. How many of you were able to write down 3 things that need to be changed? Was it very difficult to do? I can't see chat properly. Was everybody able to do this?
Yeah, they were able to do it. They're writing, I could, I did, yes, 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 ma'am. Yeah.
Okay. So my next question to you is, if you could write down 3 things that need to be changed, why haven't you changed that so far?
Not in my hand. One
Not
part.
in your hand. What you don't
Tried, but
realize, yeah,
tried to meet resistance, hierarchy. Would you please repeat the question? Not in leadership position.
okay,
Change others often requires systemic reforms. Did not know the way forward.
okay,
Behaviors take time to change. These are few
Okay.
of the inputs.
Right. So I'm just wondering that all of us have observed different things, but not everybody has the guts to stand up and change the system and ask the right questions when something goes wrong and say कि वो बाहर कैजुअलिटी में कोई मरने की हालत में रहा तो उसको फॉर्म भरना जरूरी है क्या? So we all know what is wrong, but all of us don't act, and that is what needs to change. So my advice or my request would be, wherever you are in your workplace, ask these questions. What do we see? What did we find? And how did it work? And don't wait for someone else to come and change something. Once you have to change the mindset. You explore something, you apply something and try it, reflect on whether that is working, and then if something works, celebrate. And it's not going to be a big boss coming over and telling the world will change one fine day. It doesn't happen like that. Things happen incrementally. Things happen slowly. You have to have small changes. You won't get you know avatar coming from somewhere and changing your world. So you are seeing what is wrong, you're seeing what can be better, and you are the person who will have to make these changes. Let's go ahead. So today what I'm going to do is to show you or teach you or to share with you some Lean Six Sigma tools. There are many and I can't finish that in 1 hour. So I'm going to use only 7 or 8 and give you examples in healthcare and in medical education of how we can use these Six Sigma tools. Some of the Six Sigma tools and techniques that came with Lean are called 5S, the 8 wastes of Lean, um, values, VSM or value stream mapping, Kaizen. Then there is through Six Sigma, you have DMEC, you have Pareto charts, you have root cause analysis, and statistical process control. You might have used some and all of to other people. This might sound very technical, but there are simple things, and I will try to simplify it as much as I can. So let's go to the first one, 5S. Now, 5S basically is a Japanese method of workplace organization. And it stands for these 5 beautiful Japanese terms, which sound like a poem: Seri, Seiton, Sisu, Seketsu, and Shitsuke. I love the names. But let's look at the English names for understanding it. So, the first one is sort, which means in your workplace, remove everything that is unnecessary. The second is set in order, which means organize the things that you need so that they're easy to access. Shine, meaning keep your workplace clean, keep your equipment in good condition. Standardize, so that you have a routine, you have color coding, you have checklists, and also everything is cleanly maintained in a proper order. Sustain is building your habits, building your culture to maintain and improve the system continuously. Have you heard these terms before? In what context have you heard it? And when I first heard of this, I was like, ये तो आता है. ये सुना है. कहाँ सुना है? Have you heard of minimalism? And do you know this lady, Mary Kondo, who talks about how to declutter your wardrobe and how to keep only what is minimally required? So she uses this 5S, and she's Japanese, of course. So this 5S principle and her decluttering mechanism, which everybody seems to be fond of, and Instagram reels are filled with this. They talk of uh, this 5S principle, which essentially means that there is a place for everything and everything is in its place. So that's what you mean by the 5S. And this is used to improve your efficiency and standardization. So, how do we use this in the healthcare system? I think there are many, many examples. I've used just one. Um, Say, for example, this is your emergency room crash cart. And I picked up this picture from a JIPMER module. So, this is from India. So, if you have an emergency room crash cart, you want to be sure that every time in an emergency you need it, it is perfect. You don't have to lose patience because the cart was not ready. So, it has to be somebody's job first to sort, That is to remove all the expired drugs and unnecessary items. Second is to set in order. So the drugs and the instruments are arranged in label drawers. You can see it here. So everybody knows the sequence where the airway supplies are kept, where IV access is kept. All of them have a specific place and they are color coded. Somebody has to do a daily check for cleanliness and functionality, and that is shine. Standardization, look at this here. It says uniform crash cart arrangement for all patient care zones. So the crash cart will be uniform, whether this crash cart is in obs-gynae, whether it is in surgery, whether it's in pediatrics or medicine, the same cart layout is followed in every emergency room across the hospital. And so that everybody's hands are, they know exactly where to go when they want to find something. And sustain is it's not done only when on the day of the inspection. This has to be somebody's responsibility for daily or weekly audit to prepare this kind of an emergency room card. So there are several examples, and for your own emergency setting or your own hospital setting, you can organize your workplace in such a way that these things are in order and all the clutter is removed. How do I use the same example in medical education? Say, for example, you have a learning management system for your students. It's a place where everybody is putting in their PDF files or their YouTube videos or their PowerPoints and expecting students to access it. Now, it has to be somebody's job there to sort the files. That is, remove the outdated lectures, remove the duplicate files so that the students get only the right files. The old files are not there. Somebody has to set this in order so that this is created in a structured folder. For each year, the label has to be there. Inside that year, you would have each subject modules. Inside that subject, each chapter wise you have. And then again, the lectures are numbered and kept. So this order has to be standardized and it has to be kept in a particular order. Then it is that person's job to keep the files updated, check if there are any broken URLs which are not working. If you have put a YouTube video and the video has disappeared, if you have put a link to a book or a PDF somewhere and that's not working, somebody has to do this job. Then again, you have standardization where you teach your teachers, you train them in how to name the files. So it's not that file number one, Word document one, PDF one. That's I see a lot of people still doing that. So how you are going to label the files so that students have no difficulty in accessing them immediately. Otherwise, they'll stop coming and using your LMS. And then sustaining is reinforce these practices in all your faculty development workshops. How do I use my LMS? How do I post digital learning resources? How do I update it when something new comes in? So this is also a part of removing the clutter. So 5S essentially is about Seri, Seton, Shizo, Seketsu, and Shizuku. It's about decluttering, organizing, and standardizing. And all of this leads to less waste, fewer errors, especially in patient safety, and smoother workflows where people find it easier to access. Moving now to the second tool or technique, which are called the 8 wastes of lean. Now, this essentially means this was given in Japanese, but the Americans use a mnemonic here, and this mnemonic is called downtime. So downtime stands for all of these words. The first D is defects, which are errors or mistakes requiring rework or correction. O stands for overproduction, where if you're producing more, if you're producing lots of things before they are needed, or they become redundant when before they are needed. Waiting is where it's idle time. Patients are waiting, people are waiting, processes are waiting. So all of that comes under this. Non-use talent, where there is whereas there are people with skills, ideas, or creativity, and nobody is asking them what they need. And that's a usual problem. Transportation, where you're unnecessarily making people go from door to door. You're unnecessarily having the files to move from place to place. So all of that, where you can cut it down. Inventory is excess stock, resources, or unused material. And motion in manufacturing, it refers to friction, where you have too much movement happening. But here, in our healthcare, it will refer to unnecessary physical movement causing wasted effort. And extra processing is doing more steps than necessary. So I'm going to explain this with you with real healthcare examples. So let's look at a healthcare example. So a defect must be a wrong laboratory report, an error in a prescription, or maybe a billing which has gone wrong, and therefore you have to do the work again. So that's a defect. Overproduction, where you have a patient coming to you, he has forgotten to bring his diagnostic tests, then you again order the same test again, he's paying more. So instead of this, can you have an electronic system? We have the hospital information system here, and all your records are available with one registration number. So you can go back and see for the next last 10 years what are the investigations he has got done, and how the person is progressing. Then waiting. So people waiting for long hours for consultation. By the time he's given the sample, again he's roaming around in the hospital waiting for the lab test till the evening. Or maybe the doctor has asked the patient to be discharged in the 8 o'clock rounds in the morning. The senior resident is moving around doing other things. He doesn't come back till 5 o'clock or fill the discharge forms. So till 8 p.m. at night, even though the patient has been discharged, he has to pay for another day, and he's wasted a day sitting in the hospital for no reason. This is something which all of us struggle with. You feel like you have an idea and your boss is not asking you. You all just said that. I am not part of the leadership. So, usually, the people who know what to improve are the people who are working in the workplace, the frontline staff. We think it's beyond our ego to ask the attendants or ask the nurses of how to change something. The person who's staying there and spending the most amount of time in the ward or in your workplace is never included in making the decisions. So that is failure to use people's skills or ideas or creativity. And then you have the patient carrying his own file going from one ward to the other, where if you have a computerized system, an electronic system throughout your hospital, the patient doesn't need to carry files manually everywhere. Inventory is one big problem for most hospitals, where they have drugs uh, that expire before they use, they have consumables that expire. So you how to balance between having something and being running out of stock. So this is some important. If you look at the poor nurses, they have to go to a bed and then they come back to their station to pick up something. Again, they go back. Again, they come here. So there are things like that which can be reduced. For example, if you ask people to wash hands between two patients, they will say, by the time I wash my hand and come back to the next person, um, it's like so difficult for us to finish that round in 1 hour. So what is easy? If you can keep a sanitizer at each bed, so remind the clinician that once you have seen an infective patient, or you can see any patient, wash your hands or cleanse your hands with the sanitizer before you go to the next patient. So once you know what the problem is, you can make a change. So you must be aware of where this wastage is happening. And of course, we know how many forms we make patient, we have to fill. There are some legal forms that where you can't avoid it. And can there be an electronic system where once you fill the data automatically comes to these forms? So again, the intern will be called to fill the investigation form. He'll be called to fill the radiology form. So all of this, the same data goes into multiple forms and registers unnecessarily. So all of these are wastes which need to be cut. But for that, you must know the process of how and where you can improve something. Let's take the same examples in medical education. If you have poor record keeping and you enter the wrong marks, you will have students running around you. There will be time where the student, if it happens at the university level, then again, the internal assessment marks have gone wrong. You have to do write again and again to them and get the wrong marks corrected. Students might miss important deadlines to apply for colleges because the wrong mark lists have come. So all of this is important here. Now, overproduction. You have people from four different departments teaching the same topic, and everybody teaches it differently. So, can we have integrated teaching? Uh, or you're preparing so many assignments which are not used. You are preparing so many MCQs which are never used. So, this is overproduction. Waiting. You have collected feedback But when do you collect the feedback? When there is a NAC report required. So when you have a NAC report required, your IQAC cell goes into hyperaction and they start producing reports, feedback reports. And by the time the feedback is analyzed and comes back to the department, this batch has passed. Now, what are you going to do with that feedback? You can't change anything. That batch has gone. You couldn't improve anything. So, this is things you can change. When to intervene, when the result should be back. Should it be done mid course, where you can get back to the students and say, if this is not right, I'm going to help you change something. Uh, so, this is waiting. Again, we are designing huge curriculum, we are designing teaching methods, we are designing assessment, but nowhere are we asking students, uh, what do you like and what is the problem? Why don't you come to our lectures? So there are people on the curriculum committee, there are people, but they're all on paper. For NAC, everybody has a committee in place. The IQAC cell has students, but ask them whether they've attended the meetings, have they actually done stuff? And you will find very few colleges who are actually including students as part of where they can give their ideas or creativity. Again, you have students running after you with logbooks, please sign kar do, please sign kar do. This is the usual problem. And why do they have to run around you for your signatures? If you have observed them doing something, immediately can you have an electronic logbook or can you sign the logbook right there when you have seen a procedure? So why wait till the end for all of this, where you have to keep, poor kids have to keep running around and finding you? Inventory. Again, you have so many exam questions in your question banks. Are they actually being used? You have printed tons and tons of paper with handouts. When by the time you use it for the next batch, things have changed. So there's waste of all of this. Can you use PDFs instead? Can you give them out electronically? Can you send them out on WhatsApp? So there are different ways of taking care of all of these resources. Um, Think of your timetables. One lecture is held on the first floor. The poor kids run to the fourth floor. Again, it's a different building. They miss the first 15 minutes. The teacher is grumbling because I have only 45 minutes and you've come 15 minutes late. Then the next teacher is grumbling. So think about how to organize your classrooms or lecture halls. If the student is moving between different wards and the lecture hall, how can your timetable be rescheduled? And of course, we all know how many times you have to attend. You have a biometric, and then again you have paper attendance. That is not they don't trust it, so you have to take attendance again. So double work. This all of this can be easily corrected if you know where you can change. Let's go to the next tool, which is called VSM or value stream mapping. So even forget about the big complicated name here. Basically, it is a visual map. And on that map, you are going to put in all the steps of a process. You're going to put in all the steps which add value to it and those steps which are of no use. So whatever is happening is mapped out. So there are two maps to be created. The first map is what the current state is. And that map helps you to identify where the delays are, where the redundancy is, where the bottlenecks are. And based on that, you will see at each point how much time is being taken, how much value is attached to it. And then you will now see your invisible efficiencies, and on the map, they become visible so that they can be fixed. And based on those corrections, you can create a second map, which depicts your future state. So VSMs or value stream mapping, you can use it. You can make these maps. Either you can go and use a software online where just like concept maps, you can have value streaming. Every step can be mapped out. Or if you don't want to spend money or anything, you can just use your post-it notes, stick them up in a wall and say, these are the different steps. This is what's happening here. So it's a visual outline which is being given in front of you. So I'm giving you one example here. And this example is refilling a prescription for a waiting patient. Now, in this map, each of these symbols has a meaning. A rectangle means a process. A diamond here means a decision point with multiple outcomes. A triangle stands for a product. This capsule stands for a prescription. This bottle here stands for a drug therapy problem. Wherever this man is a patient interaction, and so on and so forth. So what you're doing here is you have a patient who's come here with a prescription. He's giving it to the first technician here who takes the order and he puts it on the computer, prints the label, and then he gives the order. He attaches the label and then he gives it to the next technician. Now, this technician looks at the prescription again. He confirms it whether it with a pill counter or whether we have enough medicine here, and then he gives it to the pharmacists. But the pharmacist looks at it and says, "Is this prescription correct?" So if the prescription is correct, he confirms the count, he performs the quality assurance, and he gives it to the clerk. The clerk gets up, he goes to the cabinet, he goes to the cupboard wherever the medicine is, and he takes the required number of drugs, brings it back, bags it, staples it, and gives it to the patient. Now, if the pharmacist sees that this is not a correct prescription, he will send it back here. It takes extra 5 minutes here. And then this patient will go back to the doctor and say, the pharmacist is saying the prescription is wrong. You have entered something wrongly. This drug is not available, or the dose is got wrong. And the patient has to go back and come back here again and follow the same process again. Now, once the patient gets the drug, if the patient has any questions, the pharmacist will ask the patient's questions. And if there are no questions, the patient will go. Now, below this map, you have two timelines, and these are called I think it's called the value streams. So one is the prescription time. The time it is taking for the pharmacy department, and all the time which is up here is the time which is required. And all the time which is going down is the redundant time, which can change. So if this clerk doesn't have an organized cabinet here and he's taking longer to go and get the drugs, or if it's not alphabetically arranged, or if there are if he gets the wrong medicine, then what happens? So all of this will be measured here. But if you look at the patient's time, he's come here, he's spending these 4 minutes 49 seconds waiting and doing nothing. And then again, this is happening here. So this map tells you what are the areas where there is no value and what you can do in that phase instead. So once you draw a map, you can completely, for your own setting, change this and decide where I can cut and make the time shorter. So this can be just like a prescription. This can be from the time your patient enters the registration OPD, he stands in the queue, he then decides which OPD he wants to go to. Then he's confused whether I have to go there. He's waiting outside, waiting for the right clinician to come there. And then he doesn't know where to go. Again, he has to go to the payment counter. What is the distance between all of this? Does that man who has come on a daily wage spend the whole day trying to get medication for one fever? Right? So these are things which can improve the system, make it more efficient. Again, I'll give you an example, which is medical education example. This is an example of a student admission process. Now, I didn't have the facilities of drawing a map using the software, so I've just drawn a simple map. It's not according to all the logos and the symbols. I could not do that, so I just did it simply. So when I was a medical student, the state of affairs then, I'm writing current, but it was the state of affairs when I was a medical student. To join medicine, you first had to go and look at the newspapers and send a letter and send a money order or whatever to each medical college wherever you wanted admission. Wait for about a month for the form to come, and then you manually write the form and submit it. Then afterwards, the admission cell would manually verify all your admission forms. It took around 2 months. And then you decided to whichever medical college you had different entrance tests. I gave, I think, around 8 different entrance examinations in different places. There were scheduling delays, 2 exams happening on the same day. I could not, even after paying my registration, I could not attend one of the exams there. And once the merit list for each of them is going to be published, then you have to make a choice of where you want to go or where you're going to go. So if you have something like this, you can easily change it in the future, or now what's happened now is where you have an online application form submission. It has cut down the time. The admission cell does an automated verification, again cut down the time. There is one common entrance examination, and that is done online. And the interview dates and the publication of the merit list is integrated. So that way, you are compressing the time required for any process and making it easier for people. So if I put it like this in this table, this initially it took 6 hours, and now if I do a parallel billing and pharmacy, if I have a streamlined clearance system, then it will take less than 2 hours for the patient to be discharged. Again, for student admissions, what can I do here? So these are the ways in which you can reduce the time taken. I'm going to the next tool, which is root cause analysis. And as the name tells you, it is a systematic method used to identify the underlying causes of a problem rather than just symptoms. So, under root cause analysis, the purpose is you prevent recurrence of errors by fixing the root of the problem and not just the immediate issue. So, usually every problem has a cause, but we always forget that there could be a chain of contributing factors, and eliminating only the surface cause is not usually enough. Now, you can do root cause analysis by different tools. You can do what is called as 5 whys. We keep asking the question, why has this happened? Whenever there's an answer asked, why has that happened? So you get to the bottom of it by asking multiple why questions. Or what you can do is to draw what is called a fishbone diagram or a Ishikawa diagram. So I'm a pathologist. So suppose I get too many unsatisfactory pap smears. So I'm getting a pap smear from the gynecologist, and every time I stain it and look under it, there is no cell in it. So what are the causes of unsatisfactory pap smears? So there are some things which can be pre-analytical, and some things which I do at the processing level, and some things after the slide has come to me. So for an unsatisfactory pap smear, I have to first look at which machine. Am I doing it manually, or is there a liquid-based cytology? What is the staining quality? Is there automated screening, or is it manual screening? So there are different techniques used, and what can be improved is something I see at the pre-analytical level. At the level of the collection, is the person who's collecting the pap smear trained? Is it certified? Has their competency checked? Are we getting the same inadequate smear from the same person? Is there a record of who is taking, which nurse is taking, which Anganwadi worker is taking the smear? And is the same person making the mistake? Or is there no training happening at all? Is everybody just looking at each other and doing this work? And therefore, we are getting it. In the slide, why am I getting an inadequate smear? Is somebody wrongly using a lubricant before taking the pap smear? So is the lubricant obscuring the slide? Is there a lot of blood? Why is there so much blood? Are they taking smears during periods? Or is it actually a squamous cell carcinoma which is hidden under that blood? Is there a lot of mucus? Is the person who's taking the pap smear not cleaning the cervix before taking the sample? Looking at measurements, we have international criteria of how many cells should be on the smear. Are they being followed for the manual count or the liquid-based cytology? What about the employees? Have they been trained in the system of reporting? Are slides being randomly rescreened and seen? Are the junior people being followed up? Is the senior looking at it? We do actually what is called as random rescreening. So 5% of all slides which somebody else has seen will be randomly seen by a senior to see if that person is missing findings. So what is the slide review policy? If there is a problem, does that slide get reviewed to a senior pathologist? And the environment, do we go back and ask the gynecologist for a second slide? So this is how you look at the cause. And at each of these stages, what you can do is make an intervention and improve the system. I will take another example from medical education. So we all crib about this, that students don't come to our lectures anymore. So if there is low student attendance, you go back, do a survey, do a study, ask students, what is the problem? Is it a problem with scheduling? Are the early 8 a.m. lectures too difficult for students to attend? They study throughout the night, and early 8 a.m. is too early to get up. Is the timetable overloaded with back-to-back lectures? Do they feel bored and therefore they can't come for the lectures? Do they have a problem with didactic lectures? Um, is the lack of interactivity putting them off? Are the faculty not trained in doing interactive teaching? Are there skills which can be improved? Is the topic which is being taught relevant to them? Is what you're asking in the exam different from the content being taught in the lecture? Is there too much theory? Is it clinically not relevant? What is happening here? What about the institutional environment? Are the classrooms, do they have AC, or are the classrooms too hot and humid for students to sit in the afternoon? Um, is nobody monitoring attendance so that they all go off and do what they want? Or is it the other way around? If the administration is too strict and too punitive, then they want to rebel against it. They don't like, uh, if the whole class bunks, then what will the teachers do? Is that the attitude? Then is it individual student factors, lack of motivation, that no need to attend this lectures here? You'll pass even without it. Or are they genuinely fatigued with these back-to-back lectures? And are there external factors here? So they are all focusing on the pre-PG examination, the coaching classes are online, and in any case, YouTube has recorded lectures available. So why should I come to the lecture? So this is the kind of map or the fishbone diagram or the Ishikawa diagram, which can help you to arrive at the cause of why something is going wrong. And each of these places is a place where you can intervene. Now that you've taken up the causes, you can do what is called the Pareto chart or the Pareto analysis. So the Pareto principle is also called the 80-20 rule, where it says that roughly 80% of the consequences come from 20% of the causes. So focus on the 80%, put all your energy into that 80%, and on the critical part, which generates lots of problems. So I'll give you an example. Say you're having the surgery department is facing lots of cancelled surgeries, and they go back and they analyze all these causes of these cancelled surgeries. And a Pareto chart has two kinds of graphs. One is a bar graph, where each graph, the height of each graph tells you the frequency of that cause. So here you can see there are four different causes. One is that when the person is going for surgery, the investigation or the workup is not complete, the results have not come in, so the anesthetist refused to take the patient for surgery. Second is there is unavailability of blood, and the surgeon is not prepared to take that risk. Maybe the lack of patient preparation may be a cause. And then the other causes are clubbed here. This red line talks about the cumulative frequency. And you will see that even if I work on the first two, 80% of my cases of cancellation can be dealt with. So I will put my energy into looking at why these incomplete investigations are there. Has the lab workup not been sent in time? Are you sending it after 5 p.m. and therefore the pathologist or the microbiologist or the biochemist is not able to give the results back in time? So is there a scheduling plan which has gone wrong, where the intern or the house officer or the junior resident has not sent investigations in time before the scheduled surgery? If there is unavailability of blood, what is the problem? So are residents not able to convince the uh, patient's relatives to donate blood? Is there a problem with the blood bank? Find out what these are and then work on these two more, and most of your job will be done. For a very simple example in medical education, if I analyze all the theory papers in pathology, I did paper one, and I found that 80% of the problem, the students have made mistakes in inflammation and neoplasia. So what I will do is focus on these two topics. I'll probably take tutorials in these two topics. I will ask students what the problem is. I'll probably reteach these two topics again. So focus your energy on 80%, and that is what Pareto charts help you with. This is one of the last few. So I think most of you might be using this. These are called SPC or statistical process control charts.
Ma'am, I'm sorry to interrupt.
Yes.
This question coming up again in the previous Pareto analysis, what does the red line signify? Can you just explain?
The red line is the cumulative. So this plus this is this part. these two will come here and this is 100%. Okay. Cumulative frequency. Statistics. Is it clear? Okay. So this line graph tells you the cumulative frequency. Can I go ahead?
Yeah. Thank you.
So coming to this next SPC chart, a statistical process control chart. These are also called as Shewhart charts. And in pathology, in hematology, we call it the Levy-Jennings chart. Biochemists also will know this. So this tells you whether a process is stable or unstable. So basically, you are seeing, it's just look at it like an ECG graph. So ECG graph, you always need it to go in a straight line, and suddenly if something goes wrong, there's an arrhythmia happening. So a graph here will be something like this. So this midline is for a process as long as the central line is the mean. And if you have one value going beyond, these two are the upper control limit and the lower control limit. These are set at 3 standard deviations. So one going out of place is an outlier. That's not something to worry about. But if you're seeing a series happening like this, all of these are going, this is a trend happening here. So this is something we use very commonly with our machines in biochemistry and hematology. So you will be familiar with this. But how do I use this chart to see whether a trend is happening or whether something is going out of the 3 standard deviation? Then something to worry about. So there are rules related to that. I didn't go into details of that. You can look them up. So in healthcare, suppose I'm monitoring the ICU hospital acquired infections. So I will see that suddenly you have hospital acquired infections going up. So this needs an intervention. Maybe you'll ask, you'll take a separate workshop or a training program on hand washing. Reinforce that thing again of why is hospital acquired infection starting again. If it's a dialysis unit where you're seeing that catheter related sepsis is going on. So you will work around this issue knowing that suddenly this is increased. Again, you can monitor turnaround times in the laboratories. Where is the problem? Is there a problem with transport of the samples from the sample collection to the lab? Can we increase the number of batches and the frequency of the batches happening? Where is the problem happening? Are the forms coming incomplete? Is the history not given here? What are there wrong information? Is a new batch of interns not trained? So that kind of thing. And of course, we use it in hematology also to see whether you are having, is it by chance or is it an actual bias happening there? Is it, so this is how we use it in healthcare. These graphs help us. What you can do in medical education is to monitor attendance. So look at attendance and see in a week, where is the attendance going low? Is it a specific department lectures they're not attending? Is it a specific teachers at lectures they're not attending? Are they all coming in the afternoon classes but not coming at the 8 a.m. lectures? Where? Are they not coming before you announce the internal assessment? Do they all disappear at that time? So this will help you to monitor what is going well also and what is going wrong also. So you will know that this department is doing well, this department is not doing well. So if a department is doing well, what are they doing differently? Find out. Again, this can be used to monitor examiner variability. So you look at paper checking and find one examiner is too lenient, one examiner is too miserly with giving marks. So both of them need faculty development training of how you give marks by using the whole range. You can also use it to monitor the time taken to declare results after the examination. So at the university level, once an exam is done, how much time does it take to compile the results? Is there some way of reducing that time? What is happening here? And do students get feedback at the end of the examination? So all of this is important. What you can also do, which could have been done desperately last year with NEET, with all the hangama happening around the paper leakage, is that if for a selection or entrance exam, if you're going to monitor this course and you see that 70% of students have got above 600 out of 720, you know that definitely there is something wrong with the security. So how do you monitor scores is something which is really important in this case. This tool, I love the name of it. It's called Pokayoke. And Pokayoke essentially is a Japanese for error proofing. So you design a tool or a process or a system in such a way that it prevents errors or makes them immediately obvious. Like, for example, your USB. Your USB port can only go into a specific port assigned to it in your computer. Even if you keep it the other way around, ulta, it will not go. So the device is produced in such a way that it builds safeguards into the process itself. And that is essentially what Poka-yoke means. So where can we use Poka-yoke? In healthcare, if you have high risk drugs, maybe they have a color coded label on it. Uh, if your samples are barcoded, the problems with patient identification don't usually happen. Simple things like in most surgeons will do this. So if it's a right breast or a left breast which needs to be operated, before the evening before, they will mark the site with indelible ink. They will mark the area out of where they want to operate. That is one way of doing it. And if you look at how instruments are devised, your feeding tube connectors will always be different from your IV line connectors, and they cannot be inserted into each other. So at the manufacturing level only, you do something different so that there can be no error at this stage. In medical education, we already do this. Like if you have an online exam and if you see that a student is skipping that question, a software prompt will come. Do you want to go back to the question you have left behind? No? So that kind of questions. Do you want to revisit that question? Are you sure? So those kind of prompts come in your software. And this is where Poka-yoke works. Your biometric attendance records, which we are all plagued with because they don't trust us with our fingers, and all the illegal work that people do. So now they have come to face your retina scans and all of that. So these are all ways in which you can monitor attendance. And you can have hi-fi skills mannequins, which give prompt. You're doing CPR. If you miss a step, the mannequin itself says, check the airway. It gives a cue. So these are ways in which Poka-yoke can be used, and this is called error proofing. Now coming to Six Sigma, there is this method called DMAC. DMAC is an acronym which is used for process improvement. D is for define, where you say what the problem is. Measure is you collect data, and you A is analyze. I've told you different methods like root cause analysis, Pareto chart. Any of those methods can be used to analyze. I is to improve something and remove that cause, whatever cause you've seen by different methods now. And control is to sustain that improvement, so that it stays on. So quick examples I'll give you. One is for reducing the waiting time in OPD. So the problem is a long waiting time. Define what a long waiting time is. So at the moment, it is 120 minutes, 2 hours that a patient is waiting on an average. Measure. So what is the average time spent in the registration? How much time does he spend in waiting? How much time in the actually in consultation is only 20 minutes. Then how much time he's roaming around the billing counters? So once you have measured all of this, analyze it. What is the cause? So is it a poor schedule? There is no triage. Are your schedules overbooked? No appointments there. So how do you improve it? You have a scheduling software. Is there an EQ where the patients are called according to when they have entered the hospital? Is there a triage nurse who takes the emergency cases quickly? And then to sustain it, you have audits, you have SOPs, you have surveys, and then try and sustain that improvement throughout. Similarly, suppose you're conducting OSCEs and the problem is that you have high variability in examiner scoring. And you're seeing that the problem when you measure it is that the scores are varying between 50 and 70% which should not happen with an objective test. There is low reliability. Now, the root causes here, when you analyze, is that the faculty have not been trained. They've just been sent to look at an OSCE and mark an OSCE without any faculty training. And there is problems with the checklist. So how do you improve it? You prepare standard checklists, you train the examiners, you give structured feedback to them of where they are doing well and where they're not doing well. And to sustain it, you will have to have OSCE audits, you have to calibrate the sessions and do a continuous monitoring. So these are all different tools and techniques that are there. You have to look at what works in your setting and then decide what works best for you. There is no best method for this. In your context, whatever works is right for you. So let me here give you another story from Atul Gavande's book Better. So this is about cystic fibrosis, which is a devastating disease. And for many years, patients of cystic fibrosis died young. But when Atul Gawande visited a clinic in Minnesota, he found something very extraordinary. He found that in this particular clinics, the patients were living almost a decade longer than the patients elsewhere. So, what was happening here? The doctors there were not using a miracle drug, they were not more brilliant than others. What they did was something very simple but very powerful. They measured everything. They measured lung function, they looked at infections, they weighed the patients, they tracked compliance or adherence to protocol. They tracked each patient's data over time and compared it with the benchmark. And what they did was tiny adjustments. They added a small antibiotic there, a physiotherapy tweak there, they gave extra nutritional support elsewhere. And this they did relentlessly, month after month, year after year. And the result of this, over time, these small steps added up to extraordinary outcomes, and their patients outlived others by almost a decade. This lesson here is very clear that quality improvement doesn't come from dramatic breakthroughs. It comes from measuring carefully, from learning continuously, and making small, consistent improvements. And that is the heart of Lean Six Sigma. Now, having said that, think about your own classrooms. Very often, we'll wait till the end of the term to know how our students are doing. By then, it is too late. So, what if we tracked learning just like those people at the cystic fibrosis clinic did? Small formative assessments, give timely feedback, continuously monitor performance, whether it's an undergraduate or a resident. And instead of waiting for them to fail and then giving feedback, we could catch the problems early, we could adjust, and we could improve the outcomes. And that is the essence of Lean Six Sigma: continuous measurements, small improvements, and big results. Now, before I end, I want to give you uh, this principle, which is the heart of lean, which is called Kaizen. Now, Kaizen is a Japanese word which comes from two different words, Kai and Zen. Kai means change and Zen means good. So, essentially, it means change for the better. So, this is a philosophy which says continuous, small, incremental improvements, which doesn't come from top, which involves everybody, the workers, the managers, the leaders. And this is not a massive top down change. So, the core principles of Kaizen are that improvements should be continuous, they have to be sustained, and everybody participates. It's about collaboration, it's about teamwork, and everybody owning the change. As long as the change comes from nobody's interested, as long as the change is something you have brought about, you want to be a part of it. It's important that you don't just look at the symptoms, go back to the root cause and find out how what can be improved. And don't wait for money to come or a world to change or have a complex solution. Simple, low cost solutions are where you go for in always. Um, so in Kaizen, we do daily huddles to identify small process improvements. Say, for example, you have conducted an OSCE. Now, don't wait till the next exam. At the end of the OSCE, you can call all the students together, tell them what the common problems were with everybody is doing the same mistake. So something is wrong with the teaching. Teach them right there. Ask them where they had problems. So that kind of informal setting, or for any process of how do we change something, of why we are having problems with attendance. These are things which informal meetings in the coffee room can change. Um, you empower the staff to suggest ideas. If your system is so hierarchical that you cannot open your mouth, when you have a good idea, it doesn't work. And Kaizen usually is focused on, you can do it for both long term and short term, but this is focused on short term projects and on rapid problem solving. It comes from Japan. If you look at that country came on its heels after the Hiroshima and Nagasaki bombing. But now you go there and you see a different work culture throughout the country, and that is Kaizen, which is the cultural heart, where it is a mindset of continuous improvement. Without that mindset, you can keep using tools, it'll become a very mechanical exercise. And Kaizen is not just for business, it is for personal improvement. I'm just in the process of reading this book on Kaizen, which is by Sarah Harvey, which talks about how you can make small personal improvements and improve your own life using Kaizen. So it's an interesting thing to explore of how by little you can make improvements in your lifestyle. Now, before I go, I want to talk about this story from Vietnam. This the year is 1990, and Jerry Sternin and his wife Monique and their 10-year-old son Sam land in Hanoi from Vietnam. They have been sent by the Save by the Children at the request of the Vietnamese government, and they have been given a task of tackling a huge crisis, which is child malnutrition. On the first morning, they are called uh, to meet the Foreign Affairs Minister of Vietnam, and he welcomes them, but he gives them a warning. We have only 6 months. You have to study the problem, but also solve the problem, and in a way that that problem, the solution lasts. Now, Jerry Sternin, being the practical man that he was, he knew what causes malnutrition. He knew that it is caused by poverty, by poor sanitation, by unsafe drinking water, but he called them TBUs, true but useless. And he knew that just their couple, the Sternin couple, and a few other staff members could not fix such a huge crisis in 6 months. So he decided to try a different approach. So this small team went into 4 villages, and they took the weight of 2,000 children below the age of below the age of 3 years, and they found that 68% of them were malnourished, and many of them were at the risk of dying. But what he did was something completely different. From that list of all the poor people, he found that there were some people who were healthy. And these people he called the positive deviants. So, what he did was Jerry and Monique went and met these positive deviants who were from the same village or the same community, but their children were healthy. And when they talked to them, they found 3 important things that these positive deviants were doing differently. One, while the entire village was feeding their kids 2 bowls of rice soup per day, these families were feeding 4 bowls of soup. The second thing that they were doing differently is that the mothers of these children would go out into the paddy fields, which are so widespread in Vietnam, and pick up little shrimp or little crabs, which were there in the paddy fields. Or they would pick up green leaves from sweet potato and add them to the soup when it was boiling and to the broth. And the third thing they did differently was that they fed the children themselves. And while feeding, they would put their spoon or ladle to the bottom of the pot and take out all the nutritious bits and ensure that the children were eating those nutritional bits of shrimp, crab, or greens. So these were all local replicable solutions. And Jerry could have simply gone and announced it on a loudspeaker. He didn't do that. He started organizing workshops where these mothers who had healthy children could conduct the workshops. And the entry fee for that workshop was, if you want to join the workshop, first go to the paddy field, pick up crabs, pick up shrimps, pick up those green leaves, and then bring them, and then you will be allowed into the workshop. So what they did in the workshop was put all those crabs, shrimps, and green leaves together, made some food, and gave the children all that food. And something remarkable happened. Within weeks, these children grew healthier. In 3 months, 40% were off the malnutrition list. And this approach spread across Vietnam. It reached over 1 million children. And this also went on to 40 more countries. The lesson here is profound. The answers to big problems often lie in big, bright spots, which are already within the community. The task is to find them, to amplify them, and to make them the norm. And this is the principle of positive deviance. All the principles that we talked about have come from in Lean and Six Sigma have come from manufacturing. So all they are doing is focusing on the negatives, on the defects. However, the positive deviance tells us to focus on what is going right. And this is something you need to add to your armamentarium when you do this. Now, what does it mean for in medical education? I gave you one example earlier about poor attendance. And when we drew the Ishikawa or the fishbone diagram, we talked only about what was negative. So, what we want you to do differently is don't ask why the students are disengaged, why the outcomes are poor. Instead, you ask who are our positive deviants. So, in the same community, even though there are students who come from vernacular medium, uh, there are students who thrive despite limited resources. What are they doing differently? What are their study habits? In spite of all of us complaining that students don't come to our lectures, there are still some teachers to whose classes they all definitely come. They don't miss a single lecture. What are those teachers doing differently? What are the teaching practices that they are doing? There are some departments where assessments are going fantastically well, students have no complaints. What are those departments doing differently? So, just like in Vietnam, the answers to most of our challenges may already exist amongst us. They are hidden in those who are quietly doing better. And our role as um, medical educators is to recognize these bright spots, celebrate them, and then spread what they're doing further. And that is how real sustainable change happens. So it's clear that we need to introduce training in quality and safety. Uh, this is important for clinicians and healthcare workers. We know because you need to ensure patient safety and reduce error, improve efficiency and patient satisfaction. And these are the topics that we will need to teach them about all the protocols, infection control, clinical decision making, how to communicate, how to be good leaders in multidisciplinary teams. And how do we do this? You can use your simulation or skills labs, you can use interdisciplinary training by reflective practice, clinical audits, conducting workshops. For faculty, remember, medical faculty are those who prepare future doctors, and they need to teach in an inspiring way, teach in a relevant way, in an evidence way, because they are accountable to the kind of doctors who we unleash on society. So they need to know the principles of CBME. When they assess, they should know that when I am telling somebody is competent, that person is actually competent because we're adding another person to our profession, and that person better be good. So they need to have good feedback skills, better mentorship skills. And how do you do that? With faculty development programs, with peer observation, giving feedback, and blended learning, both online and face-to-face sessions. We also will need to train our medical students because we need to build competence and confidence for them because when they go out into real life, they need to know these things. And this is important to reduce the transition shock from classroom to clinic and to promote a lifelong learning mindset. So we do teach them now with ADCOM coming in. You need to teach them clinical skills and professionalism. We started teaching them evidence-based decision making, teamwork, and communication. What I find lacking and what is there with ACGME competencies and not with ours is this competency called systems-based practice. If you see something wrong with the system, how do we change it? Is never discussed, is never taught, and we ourselves don't think about it. So one very important thing is to actually implement the student doctor method as soon as possible in your institutions. It's also called the clinical clerkship. When a student spends time with a unit, he will see where the deficiencies are. You can ask that person to write down reflections or even ask this person to see what can be improved, include them in that process. You can give them case-based problems or problem-based learning or skills in the portfolios. All of this can be done. So my favorite of this is the student doctor method, where the student learns from the time when the student or when a patient is admitted to either discharge or death or whatever, or disability, what a patient goes through, and can we change something in that? So make them aware of the system. I love this. In the last NCHP, Dr. Mahalakshmi from Pondicherry actually presented how groups of 10 students with a facilitator were sent to different parts of a hospital. They went out to the registration OPDs, they went to the pharmacies, the blood bank, palliative care units, the different wards, and they themselves identified what can be changed. And based on that, they suggested changes and submitted projects. So this kind of real authentic, real life setting learning is something which works. And take reflections seriously, give them a structure to show what can they change within themselves. Peer mentoring works if you have positive deviants who come from the same community, who are not maybe toppers but from the same community, and if they are a good match, that also can work. So this is part of my MHP thesis, where inspired by Atul Gavande's book The Checklist Manifesto. um, Usually checklists are used for decision making where it's linear, like in an aviation industry or a OT. So that's where you use checklists. But the question, and you can always find different places. But my question was, are checklists also useful for diagnostic reasoning in domains where reasoning is non-linear and more complex? So I am a pathologist. So I used a checklist for like every system. Like if I'm seeing a slide of a lymph node, there is a checklist which tells me, have you seen the capsule? Have you seen the sinuses? Have you seen the cortex and the medulla? Is everything normal? So like that. So this could aid in decision making, but more importantly, what I found that checklist works as verification tools, and the results of my thesis were that diagnostic accuracy increases on verification, whether you use a checklist or not. If you go back and check your diagnosis again, um, like these days, I think all of you have up to date on your mobile phones or wherever, and that you use to check for the latest clinical guidelines. Similarly, pathologists have a site called Pathology Outlines. So when I write my report, even if I know the condition, I will go back and check and see, is there a definite prognostic variable which I have forgotten in the report? Should I put the grade or a spread, or should I advise the clinician to do something else? So these are things that can actually be used in practice. So to end with, these are three books by my favorite author, Atul Gawande: Better, Complications, and the Checklist Manifesto. This should be mandatory reading for every doctor and every medical student. And if you're part of a health humanities uh, team in your institution, please make this happen. Um as medical teachers and healthcare professionals, we often face systems which, as you said, feel too large, too rigid, too entrenched to change. But this Lean Six Sigma approach shows that even the smallest changes, a checklist, a feedback loop, a standardized process, can transform patient care and student learning. And we have seen how ICUs reduced deadly infections, how OTs became safer worldwide, and how schools can also cut cost, cut waste, and make learning fair, more meaningful. So the real challenge is not technical knowledge. It is the willingness to see problems as opportunities. It is the courage to measure, to reflect, and to improve. And therefore, I wanted to leave you with these words from Atul Gawande, words that capture the very spirit of what we discussed today. Better is possible. It does not take genius, it takes diligence, it takes moral clarity, it takes ingenuity, and above all, it takes a willingness to try. And that willingness to try is in our hands. If we take it, we can make both our hospitals and our classrooms truly better. Thank you very much.
Thank you so much, ma'am. It was awesome. I do know that how difficult and how extensive this topic itself is, but with simplified examples, not only related to the healthcare, but also related to the education for each and every technique which you explained in a very simplified manner was really, really awesome. You can see the chat box having so many thanks going on for the session, which you really explained in a very simplified manner. Thank you so much. I'll be taking up question. There's one hand raised. I'll just unmute Purnima. Dr. Purnima is there?
Hi, Purnima. Good to see you here.
Yes, ma'am. Amazing, amazing. I mean, as a medical superintendent, I think there are so many takeaways from your lecture. Thank you so much. And I just want to mention regarding this group audit you had mentioned a while back. Right. So this, I did it during the electives. for the first batch when they had come, and I was there at that time in Jorhat. So I could find, students coming up with such amazing inputs, like to the extent that, okay, there is no marking over here. I think we should have some kind of, for the patients to understand which way to go. So small things they came up with, so which we could change in the hospital, and that really made a difference.
We
So
don't usually include them when they are the brilliant minds that we have. So it's like,
thank you so
yeah,
much.
yeah. Thank you so much, Purna.
There are two more hands raised. One, Dr. Amira.
Yes, Dr. Amira. Hi.
Kindly unmute yourself.
Yes, thank you very much, Anshu and Pooja, for this session. I was so motivated to attend as I teach the patient safety course for the undergraduate students. It took me a lot to prepare the content for that course. And I consider this lecture one of my resources for the self-development to improve the course. It was very nicely simplified and tailored. And also in the faculty development, it also sheds the light on how to apply these principles of Lean and Six Sigma in the medical education. That was great, actually. I would like to get your advice or suggestion if I need to make activities for the students to apply these concepts while they are studying the course. They are not yet internships. Have you ideas that you can share with me, considering that our context is somewhat similar because we have huge numbers of students. The minimum batch of students is 200 students. So have you any ideas about the activities that
Yeah, I just
can
talked
support?
about
Thank you.
what Dr. Mahalakshmi had done, where they had small groups with a facilitator each, and maybe on a Saturday afternoon, they all went around to different parts of the hospital. They allotted them in groups, and they actually saw the process first happening. They mapped out the process. Like suppose you went to a registration OPD and saw if a woman had come to the for some work, how much time does it take her to go from the registration OPD to whichever consultant she wanted? And in the middle, how much time at the billing counter, how much time to go for the investigations, how much time did she have to wait for the results or the reports to come in? And did she lose a day's wages? So little things like shifting the sample collection near the registration OPD or shifting the billing counter right there, adding an extra billing counter. So these suggestions came from students. So where there are enough toilets in the hospital, where there are enough clean water areas. So things which where the patient's going back satisfied. Uh, was there a problem with language interpretation? So I was just in a different hospital the other day, and I saw in Tamil Nadu, and I saw there was a northeast counter. So I realized there were lots of Bengali patients coming in. That so you had a person in the all the registration OPDs there. They were manned by people who could speak Bengali. So little things like that, unless you mark down the flow, you will not be able to correct it. So
Yes, thank you very much. This
thank
is a
you.
very nice idea. Thank you very much.
Thank you.
Thank you so much, ma'am. I will be able to take only one question because we are about to complete the session. I'll take from Dr. Mrinal. Kindly unmute yourself.
Hi. Hi, Dr.
Hi,
Anshu.
Mrinal.
Hello.
Hi,
Yeah.
Mrinal.
Yeah. Hello, Dr. Pooja. Excellent. And it was such a nice flow. And Anshu, I really admire the type of examples that you were giving from health science and then in medical education. And it really made a lot of sense. It sort of opened a lot of avenues, something that we have been doing. Okay. I mean, as NABH accredited, initially it used to be really difficult to find out, okay, what should be the quality question that I should ask in my own department, being a surgeon. Like, so we started looking at our pre-operative checklists. Okay, then whether our consent checking. So we had to really scratch our head initially. But now today, after your examples, what I have realized is the short projects that my students have been doing, I've been doing with them. Like it was about, say, the education level of the diabetic patients and just a questionnaire. So the project stopped there and there, where they just presented a report. But now I realize those examples or those observations can be a starting point for audit kind of thing, or the Six Sigma approach that you have described, So the gaps which were there in the patient's education. The second project that I did, we are analyzing the recent findings. The staff members in our own hospitals and what is their awareness about varicose veins, especially those who are standing for long hours. So I am in the process of analyzing the results. The ICMR project will end there, but what I have realized now that this needs to go back to the hospital, and we need to maybe change the approaches of our own staff members and see to it that this goes back and not just into the ICMR project of student and end it there. So I think this is what I have gained from and it was such a nice and fluent and definitely made 200% sense. Initially I was scared when I read the topic, but then it makes a whole lot of sense. Anshu, thank you so much.
Thank you. And all these kind of projects are probably quality improvement projects. They
Yeah.
might not be proper educational research or evaluation as such, but
But
it's like an audit where you do find out what is wrong. You can, I think, still publish it saying that this is the process we followed. And if the
okay.
process is good, and the steps are good, and then what intervention did you do after that, and was there a change after that? That could still get published as a research also. So
Yes.
it might not be pure hardcore research like that, but it's a
Yeah.
quality improvement project which other people need to know. So
Yes.
do try
Yeah.
out these small little things.
Yes. Thank you. Thank you so much.
Thank you.
Thank you so much. Thanks a lot. I think I did the right choice for requesting you and you able to spare time to talk about this particular topic, which actually many people questioned me as well, that why you are keeping this topic. I said, no, I want to have this to
I also
stay.
questioned you. I spent lots of sleepless nights wondering how can I use it. But
But
yeah, it was worth it. I
it
learned
was
so much.
good, and really, thank you so much. I think many of people, participants, I'm sure they might have got immense ideas, not only about the quality care in the hospital setting, but also questioning themselves how they can improve their educational outcome by asking the questions in the form of why it is happening. So thank you so much. I'm really sorry. We are really about just exceeded 2 minutes for our webinar. I wish we would have longer time, but maybe next time. And thank you so much for having you here. Is an honor for us.
Thank you so much for inviting me. It was a pleasure doing this. Yeah.
Thank you. And the session will be on the Facebook PU webinar page, and we have already shared the link. It will be open for all. It's already been shared. Thank you so much, ma'am.
Thank you. Bye.
And thanks to all the participants for being here and providing the interactive talks. There are participants from Indonesia, Pakistan, Egypt, India as well. That's very true. Thank you. Thank you all.
Thank you.
Thank you, ma'am. Thanks a lot.
फोटो हम शेयर करेंगे ग्रुप्स में, जहाँ ग्रुप्स में करेंगे, मतलब इसमें नहीं हो पाएगा क्योंकि 77 participants were there. So
Yeah, participants, the link will be shared on all the groups once it is publicly available from the IT group. We'll definitely share it.
Thank you, Pooja. I leave. Thank you.
Thank you, ma'am. Thanks a lot.
Bye.
Thank you.
Bye.
Bye-bye.